Good morning. My name is Dana Coulthard, and I am the Administrator of Healthcare for All Minnesota, and I'll be the host of this webinar this morning. Thank you so much for joining us. We're going to be going from about 9:30 to 11. If we can have the next slide, please. So for today, we have a number of presenters. We'll start with our chair, Dr. Mark Brockie. Then our Secretary Treasurer, Don Pylkkanen, will present on a couple topics. He'll be presenting on the financial report and the legislative committee. We'll have Carol Engelhardt, who will be talking about some upcoming fundraising. And our featured speaker, Dr. Aleta Borrud. Rose Roach, the Executive Director of M&A, will also be speaking, and also our Vice Chair, Ann Jones. Next slide, please. And then this just goes through the agenda for today. So as I said, there'll be some remarks from our chair, a treasurer's report, Carol on fundraising, Aleta on the rural healthcare crisis, our legislative priorities. Rose is going to talk about some updates and organizing for winning reform, and we'll talk about education and outreach and some announcements, and I'll do the wrap up. So we'll start with our chair, Dr. Mark Brockie. Mark, would you please unmute and come back on video?
Good morning. Thank you all for joining us. This is one of those mornings when most of us would rather be inside rather than running around out in the cold. And I, for one, am very grateful for the invention of central heating. My apologies for looking a bit shaggy. I'm currently waiting to get my vaccine before I go out for another haircut, and it's taking a little longer than I anticipated. I think that we're going to have a most interesting meeting today. The guest speaker, Dr. Aleta Borrud, who has spent most of her career at the Mayo Clinic, was a candidate for the Minnesota Senate and came pretty close to winning the race. So we're hopeful that next time around she makes that extra step and gets to be a representative for the Rochester area. Later on in the meeting, you're going to be hearing about healthcare legislation in the 2021 legislative session. But I'm going to concentrate on some other issues right now. I think it's important to remember that Healthcare for All Minnesota is not the board of directors, not the people that you see on this webinar, but it includes all of the people who are on the mailing list of Healthcare for All Minnesota, all of the people who are attending the current webinar today. If we are going to succeed with our long-term goal, we need your help. So I think you are all familiar with the saying, you can lead a horse to water, but you can't make him drink. I have a variant on that relevant to the legislature. And that is, you can show a legislator a good bill, but logic will not make him support it. On the other hand, if you and his other constituents are calling him demanding action, he will be the first to tell you he has always been a supporter. So you are part of the plan. I would like to suggest that you consider trying to have conversations with new people each week regarding healthcare reform. And one of the techniques I've been trying to use is what I call the Jesuit method of asking questions. So for example, you could start out by saying, do you know how the cost of drugs in the Netherlands compares to the United States? And surprisingly, the answer is that drugs in the Netherlands cost about 1/3 of what they do in the US. Another question that I think is of interest to conservatives and businessmen is you can ask, do you know what Warren Buffett says about US healthcare? And the answer to that question is Warren Buffett says, healthcare is the tapeworm of American economic competitiveness. There are, I'm sure, lots of other questions that you can come up with, which will also be great conversation starters. During the last 12 months, the HCAM board and our committees and teams have been doing a lot more than waiting for the vaccine to come along. We have been working on fundraising so we can hire a staff person to increase our work capacity. We have been producing webinars about reforming healthcare. We are working to increase our collaboration with other progressive organizations in Minnesota. Numbers do matter. What better way to increase our numbers than to join forces with other organizations? So just a few brief words about how we look at the next 2 years. And you might ask, well, why are we talking about 2 years? And the reality of the situation is that the Minnesota legislature is currently constituted in such a way that it's unlikely that they will see that healthcare finance reform is something that the Senate will be willing to move forward with. So for the next 2 years, our plan is to organize voters and organizations in Minnesota so that when we have a legislature that is willing and ready to act, we will have a critical mass of voters supporting healthcare reform. I think it's important for us to realize that progress is being made. A large majority of Minnesotans currently know that the non-system of delivering healthcare that we have is broken. They just need a little help knowing what the correct fix is. Business needs to be our ally, and indeed, there are a lot of businessmen who are already advocating for healthcare finance reform and single-payer healthcare. It makes sense for business. It makes it easier for them to hire good help. It's more affordable. Some of them aren't even able to offer healthcare in the current environment. And the ones who do offer healthcare will tell you that every year there is a big time-consuming hassle when they have to reevaluate what the insurance plan for their employees is going to be for the next year. You might wonder, what are the organizations we're talking about? Well, we're not limiting ourselves to any particular organizations, but some of the organizations that we already interact with are worth noting. There is the Minnesota Nurses Association, Growth and Justice, the small business group Main Street Alliance, the Minnesota Farmers Union, Physicians for a National Health Plan Minnesota, the Land Stewardship Project, the Minnesota Academy of Family Practice, Move to Amend an American Promise, unions, and churches. At the beginning of the 2023 legislative session, we want every voter in Minnesota to know health care can be fixed. At the beginning of the 2023 legislative session, we want every legislator in Minnesota to know that his constituents expect him to support the Minnesota Health Plan. So I'm looking forward to all of you helping us with this work. If you have thoughts or ideas that you think might be helpful to us, please contact me. My contact information is on the screen, and I will be delighted to chat with you. So I'm now going to turn the screen over to our treasurer, Don Pylkkanen. And the last thing I'd say is that Don would like to manage more treasurers, so we hope you're going to help him out.
Good morning, everybody, and thanks, Mark, for your opening comments and getting the meeting started, jump-started on this frigid Minnesota morning. And I really appreciated your mentioning building up the critical mass that we're going to be needing after this biennium. Due to the circumstances that you mentioned, there is that divided situation at the legislature, but that's not going to hold us back from moving forward as much as we can on the critical healthcare legislation that HCAM is all about. Getting back to the Treasury's report, it's nice to report that HCAM's fundraising in 2020 raised $22,000, which comfortably paid the year's expenses of $9,400, leaving a net of $12,600 for the year. So financially, this might maintain our current level of activity in the metro area and some greater Minnesota areas with our all volunteer work on education, outreach, and legislation, which meets the highest standards of volunteer time, skills, and commitment to a cause. And it's a great cause. However, HCAM's work plan for 2021 is to begin expanding to a statewide campaign. And although Mark and Ann and others are going above and beyond to reach out to greater Minnesota folks, they just don't have the time and capacity for the daily contacting, coordination, and follow-up that a statewide campaign demands. Therefore, HCAM's development committee of Jim Hart, Carol Engelhart, Mark, Dana, and myself set a 2021 fundraising goal of $50,000 to hire the best organizer / coordinator we can find. But an annual gross of around $22,000 and a net of $12,600 that I previously mentioned, that's hardly sustainable to pay the salary of a top organizer coordinator. So the development committee has started meeting with a few unions for funding, which looks promising. And there are 2 anonymous donors. So we're looking at $14,000 in pledges so far in 2021. Also, we'll be doing another a-thon this spring, like we did last October, followed by another crooners event in late summer or fall. And after 6 months of processing by the IRS, we're expecting 501c3 status for our education foundation in March. And we started the process submitting our application last October for the 501c3 status. So we'll be needing that for grant applications to the foundations that we're looking at. These are several sources of revenue for us to grow to a true statewide campaign, which still needs you and others to help with whatever you can. So this is a friendly reminder that you can easily donate online by going to the contribute button on the right side of HCAM's homepage, which brings up the donation page where you can quickly click on the contribution amount and fill in your contact and credit debit card information. And as we await our 501c3 status, you can still get a tax deduction by writing your check to the COACT Education Foundation and putting HCAM donation on the memo line. As always, our good work for a single payer speaks for itself. For you to consider contributing, and thank you for your attention on this. And now I'm really pleased to introduce to you Carol Engelhardt, who I mentioned earlier. She's a driving force on our development committee and was the driving force of last October's a-thon, which succeeded in raising $3,500. So take it away, Carol.
Good morning. Okay, I'm going to start sharing a screen, and I want to welcome you to hear about how we can creatively fundraise when we work together, as a team. So I'm going to share the screen now for this. All right. Okay, a fun way to raise money. Can everybody hear me? Last fall, with only 7 participants as a pilot, we raised $3,000, I have the wrong comma there, $500, which is pretty amazing. And how we did this was we recruited people to pledge to our month-long walk or swim or bike or run. And we did it with people that didn't even live in the same state or friends or families. And we did it with a personal story of why we wanted change. We said, we're getting in shape for the month. And we want you to, will you please support us? Because my husband's in my situation, we said, because my husband's sister, Carla, died of pancreatic cancer. And while she was fighting for her life, we didn't feel it was fair that she had to fight to pay for her health care too, and that her family would have been bankrupt if we hadn't have fought for those payments. So that was how we did it. And it was on a platform that we will use a different one next time, that you automatically register. So this May, by walking, biking, running, or swimming, you can log your activities throughout the month. It's on your honor. You go onto the platform website we choose for the campaign and register. You recruit the donors to pledge to you or the organization. They can just do it general, and they can do it anonymously. You exercise for a cause and get fit this spring in a fun, socially distanced way. We cheer each other on with online messages. Friends, family, and neighbors, no matter where your contacts live, they can support you in this a-thon. As simple as a one donation pledge of $1 per mile or $30 to $50 one-time donation. And they can also cap it. Like, for example, Don Pylkkanen swims laps for his. And so if he's doing it 32 at a time, you may want to cap it that you're going to give $100 or something, because, I probably did 60 miles in 1 month of walking for mine. And so that's not as much. So it all adds up to reach our goal. Let's think about it. If 30 people receive $300 a piece, we'd have $9,000. So it's a pretty amazing way to build a movement and also spread the word about who we are and why we care at the same time. And actually, when you think about it, if somebody's struggling for finances because of the pandemic, to pay their rent, to pay their health care, to pay their groceries, then obviously we aren't going to ask that person. We don't want to add another layer of burden. But otherwise, when you think about it, $30 or $50 isn't all that much. Now, because I was asking for both Ken and I as a married team, I stuck with 30, because then I was asking them to give 60. So that's why I came up with that amount. So it's all virtual. We're not going to do this in an unsafe way. You're on your honor to record your daily activity. We can support each other as a team of people getting in shape and supporting Healthcare for All Minnesota to raise enough money to hire a coordinator. When a dream becomes reality, it's because of the hard work of all, not just one person. We support you. If you sign up, we support you with your phone and text support. We will help with messaging to recruit donors. We will help with any posters or signs for a visibility day. We'll be ready for any questions about Healthcare for All Minnesota or how to participate. In other words, you're not going to be left on your own. Same day walk and sign up. Now this part's what's exciting too. On one Saturday, we can have socially distanced tables, clipboards, informational materials, and sign up, and then we would enter the people that just wanted to join the email to find out about us and get more information. We can have walkers and t-shirts walking in the same area like West River Parkway in Minneapolis, a public walking path in Mankato, Duluth, or Rochester. You want to choose a walkway for the Saturday sign up that is highly visible to the community. Now, it's fun to go out and walk in the woods, and I'm a big fan of it, but this is not the day to do it. We want visibility in a socially distanced way. It's all virtual. We will be sending out emails and calling people to join us. If you want to help and participate, please contact me even today. You can be on an interest sheet. I already started an Excel Word doc that I'm going to put in Google Docs. So therefore, we can keep one list for people that are going to do it, because we'll have a Zoom training to teach you how to do it, how to sign up, how to recruit, what messaging can be done. And then also, of course, we'll have a list of people that actually register on the site. There's my phone number I've shared too. Chapters could have teams and rally community supporters to participate. So let me go on to this part. Celebrate, celebrate. Of course, we need to celebrate together in a way that we can safely. One idea is to have an outdoor rally at the Capitol steps. Socially distanced picnics in each area that we've done it, with people providing their own takeout meal and keeping your distance. Music, signage, balloons, t-shirts by all who participated. It's time to celebrate and bring that new energy to this cause. Show our communities we care about everyone getting healthcare when they need it. I guarantee if we're at the Capitol, or if we're at Waban Park, or we're in Rochester or Duluth by the lake or something, and we have t-shirts and balloons and music and posters, people are going to ask us what we're doing, and we can respond in a socially distanced appropriate way, and hopefully get some media out there too. Okay, how do we hook the fish? All right, this summer, I couldn't believe it. I guess because they couldn't go to the Children's Museum and the zoo and the water parks, our grandchildren fell in love with fishing this summer off our dock. Fish after fish was caught daily. And when they got up in the morning, they tried to just recruit an adult because they couldn't be on the dock by themselves to get down there as soon as the sun rose. And they stayed there until we dragged them off the dock for lunch. So how do we get the people to join us, like our eager grandchildren catching fish? We tell the personal story of why we care and why we ask them to support us. It's one-to-one organizing. We have our toolkit of information to share that's on the website, and of course, we'd help you with that. Join our email list and getting on our website, and asking someone else when you talk to them to pledge to you to do the same thing. That was a mistake I made last fall. I didn't ask them to do that next step. Joining the email list and teaching them how to do that. Well, would you please join this too, so you can keep updated, so you know why I'm caring about this, to join our movement. We are the dream makers. And I want you to think of that, and your own homes now watching us, say this: we are the dream makers. Wouldn't it be wonderful if we raised 20,000 instead of 9,000? When we all work together to make a dream reality, we are the dream makers. We need funds for a full-time coordinator organized to build our statewide support before 2022. Join us. Be a dream maker this May. Now, contact information is me. And then I also put on the website. It's easier if you do the hca-mn.org. Watch our Facebook website and emails. We'll be putting this out. Stay tuned and get ready to walk, run, bike, or swim and be a dream maker. And please email me today if you're even thinking about it, and I'll add you to the list. I would love it if I had 20 people by the end of the day on my Google Doc that we will be sharing. Okay, so that's the end of that. And then I would just like to briefly tell you about some other things going on that will also be, you'll be informed about, and we hope that you can do. Crooners, we're very thankful. Mary T has said we can have an evening with John Kolstad that's no cost to us. So you know how usually at fundraisers, you rent a place, you've got the meals to pay for, everything else. It's just individuals going there and paying for your meals and drinks. And then everything goes, the profits go to Healthcare for All Minnesota. And with that, we can do some background things like have matching pledges at the same night, where silent people behind us say, I'll give $50 if you give $50. If we can find some raffle baskets like the twins for 2022, I don't know if anybody was wanting to go this summer, I would promote that, but a lot of times that you can get the 2 free tickets for a fundraiser, and we can look into fundraise for that. So that's what's ahead. We're going to pick a day in probably August to do that. And there will be also other opportunities, maybe a business match for maybe a business would be willing. And if you know anybody, let us know, where 20% of the profits for that day could go to Healthcare for All Minnesota. We might be putting out on Facebook, letting you know by email that there's a day that you could shop, like at that gift store or that bike shop or something, and it would go towards our profits. So that is what I wanted to tell you. And I thank you so much for your time. And I'm asking you today to be a dream maker with me so that we can finally have a day where every Minnesotan gets healthcare when they need it, from birth to death, and not go bankrupt. That's it. Thank you.
Thank you so much, Carol. That was very inspiring. I hope everybody feels very inspired to help us meet our goal. Next up, we have our featured speaker, Dr. Aleta Borrud. Dr. Borrud grew up in Western North Dakota, the daughter of a family practitioner who was also the owner of a wheat farm. Her undergraduate studies were in sociology and economics at Smith College in Massachusetts, and she obtained her MD and Master of Public Health at the University of North Carolina, Chapel Hill. After training in internal medicine and geriatrics at Mayo Clinic, she remained there for 20 years. She focused on developing system-wide processes to improve safety and reduce adverse events in hospitalized elders, delivering dozens of lectures on these topics in the US and Brazil. After retiring, she has devoted her efforts to expanding our public health insurance program, Pylkkare, to all in need, working with the Land Stewardship Project on behalf of rural communities. She ran an awesome, though unsuccessful, campaign for the Minnesota Senate in 2020 with the goal of helping transform Minnesota's broken healthcare system. So I would like to turn it over to Aleta.
Oops, here. Well, thank you all so much. It's such an honor to be with you all. And I am very excited, I have to say, about the possibility that you bring to expanding people's understanding of the need for healthcare and the real solution that's workable for us with this plan to really build a statewide program and hire an organizer. This is exactly what we need. And many might know that I've been working for years with Land Stewardship Project. And this is how I come to this topic, but I'm by no means an expert. I'm just sharing my thoughts on this topic. I know that there's others like Dr. Crossan on this webinar who's observing, who are experts. And then we've got people like who's going to follow me, like Rose Roach, who are real role models in finding solutions on this. So let me just start. Some of the issues that I'm going to cover is just what's happening in terms of the consolidation of our healthcare systems, the levels of rural poverty and what it really means in terms of people's ability to pay and how that stresses our rural healthcare facilities and providers, the struggle to really retain services in our rural areas, and then just looking what's the future here. Just to talk about the consolidation in healthcare. This is something that's a phenomenon that's going around across the country. There have been 135 hospital closures in the last 10 years. And in fact, Mayo Clinic, Mayo Health Systems has both bought up lots of rural facilities and then consolidated or closed them, including a critical access hospital in Springfield and Albert Lee Hospital, which was considered a sole community hospital last year or in 19. There's also been the problem of a consolidation of what they call service lines, in particular OB, because of the fact of the high cost of malpractice insurance for obstetricians. And then there's also the question of paying for things like emergency rooms, where you need a lot of providers 24 hours, and yet you have perhaps small numbers of patients using those services. In addition, there's this phenomenon of what they call bypass. Somebody will present to a rural hospital, and they'll see that this person really is going to require cardiac catheterization, and they get referred on to a tertiary care center who really reaps the profits from that episode of care. So along with this increasing in consolidation, there's lower competition. We can see in particular, this is Southeast covered by Mayo Clinic. There's really increasing consolidation, and with that, we have less competition and higher costs. And as we know, the Southeast region has the highest insurance costs, premium costs on the individual market because of this. In the metro area, there's a lot more competition, and this is where the premium costs in the individual market are the least. Just to say how urban hospitals really capture profit, I don't look at all this writing here, but just make note, the blue is urban, green is rural. So these are the numbers of hospitals nationally in 2018, almost equal numbers. But when you look at who is capturing operating revenue, 88% are the urban hospitals. And then when you go and look at revenue, per patient expense, urban hospitals are capturing 96% of revenue. This is a map that I get from Minnesota's resources, showing that there's really consolidation of poverty in our rural areas. You can see all these green areas are areas that are considered concentrated poverty versus urban areas, such as this is adjacent to Grand Forks. This is Moorhead, Duluth, the metro, Rochester areas. So, people in very isolated rural areas have just a fraction of the income of urban areas, and only 1.4% of incomes above the state median income. And so if you think about this prior map in terms of where there's poverty, it's these isolated kind of rural areas that have poverty, and these are also the places where we had rural hospitals that had negative margins, in the last 5 years. And several of these, in fact, have closed. This hospital right here in yellow is Albert Lee Hospital. And one of these other hospitals is Springfield Hospital that was closed by the Mayo Clinic Health System. One thing that I'm not sure all the reasons for, but of all the states in the United States that have expanded Medicaid, Minnesota actually has the highest number with negative profit margins. And right now there are 9 rural hospitals that are considered highly vulnerable to closure. And it might be because of the high levels of consolidation of healthcare systems. To say a bit about healthcare spending, here's a kind of an average weekly wage over this period of 14 years between 2004 and 18. And yet this is the per person healthcare spending. It's really outstripping the growth in income and just the growth in our economy overall. But what's really notable is that when you look at who's assuming those healthcare costs, a lot of it is an individual person. When you look, health plans here, they're actually compared to the cost of care, health plans are actually assuming less of the cost, and there's more cost shifting to enrollees through deductibles, the high deductible plans, and also copays, pharmaceutical costs. To say something about the uninsured, there was even a report that came out very recently that showed that even during this COVID epidemic, the numbers of uninsured has remained stable due to the fact that people have been able to enroll in Minnesota care and medical assistance. But overall, more people in rural areas are uninsured than in urban areas. And that's because of what I had already said, that the premiums are actually higher in isolated rural areas than they are in urban areas. They're because of the lower numbers of insurance carriers. There's less competition in those markets, in the individual market. And people are buying in the individual market because there's fewer people who actually have employer-based insurance in rural areas. And of course, we have larger numbers of undocumented people working in our rural areas. And so the uninsured are twice as likely to carry medical debt, yet, are poorer, actually. So this is a real burden on our rural hospitals who are carrying higher levels of debt because of the numbers of uninsured. And then again, because of these high premium costs relative to income, people are buying what's called high deductible health plans, the bronze plans on the individual market, which are really catastrophic plans. People really can't afford to pay the copay to actually seek preventive care. Maintenance for their chronic health conditions. So they delay care. And then when they do present for care, actually have a need for a very high level of care. So they might present to a rural hospital, one of those critical access hospitals. And they realize this person, is going to require an ICU at a tertiary care center for, high level of care. Well, because of these folks have bought a high deductible plan, most of them are not able to actually pay their deductibles. So the first site of care, that rural hospital ER, is going to be the one to eat the debt of that deductible. And the tertiary care receiving hospital is going to get paid by the insurer. So rural hospitals actually disproportionately eat debt from people deductibles. So the debt, you can see, increased remarkably in that very short period from 2015 to 2018, from 617 million to $56.5 billion. So just to kind of summarize these financial stressors on our rural facilities, a lot, it's, what I heard so much at Mayo Clinic, it's we have to fix that patient case mix. In other words, we need young private pay patients, not those patients who are in the old, rural areas who are older, poor, have more chronic disease and disability. Those patients in rural areas are disproportionately on Medicare, Minnesota Care, and medical assistance, or are uninsured or underinsured. And so again, those rural facilities are actually capturing less revenue for an episode of care because of the bypass phenomenon that I talked about, and then the high deductible plans. Another stress on rural facilities is the shortage of providers. There's been consolidation in Minnesota, especially the what they call birthing centers, providing obstetric care. Because of because of the difficulty both recruiting people, but also because of the cost of malpractice insurance. And so there's been a loss of 38% of facilities lost OB services in 15 years. And now we have 29 Minnesota counties without OB services, which increases infant mortality significantly. There's other shortages, especially acute, as mental health and then primary care. A lot of areas have doctors who are actually over 75 who are planning on retiring. This is just a map showing the dire situation with mental health services across Minnesota. because there's higher levels of acute mental illness in rural areas, higher levels of opiate use, and most of Minnesota counties have a shortage of mental health providers. And while this looks similar to what the map for primary care, it's not quite as bad. There's more areas that are considered partly short of primary care providers. So some of the difficulties that we know in terms of retaining providers in rural areas is, it costs a lot to go through medical school, and for younger providers who are coming, graduating, you're expecting a certain amount of income to pay off that debt, and yet the pay will be lower. There might not be the same amount of amenities. I know there's even housing shortages in areas. This is something I heard in terms of recruiting people to Albert Lee, for instance. And then, of course, we've got declining rural population. And then you've got, just to maintain services, you've got a high overhead cost, but yet you have low patient volumes. And one of the few exceptions is, areas where we have high numbers of what we consider in-migration of, foreign-born residents, say in Worthington or in Stearns County. People who are working in our meat packing plants and poultry packing facilities and other facilities like around St. Cloud. And then, of course, the question of aging providers. And then one other issue that is really quite dire, actually, is the fact that most ambulance services in rural areas are staffed by volunteers. People just are working too hard. There's fewer people to staff those volunteer services, and apparently about 65% of services can't staff all their shifts in advance. And COVID-19 has really exacerbated this problem. One of the things is that our current payment system, especially for rural facilities, they have depended on outpatient services for income and elective procedures, both of which are really not happening in the midst of this crisis. We have this, problem with volunteer ambulance services. And then there's this effort on trying to just move towards telehealth. Well, I was just speaking with a farmer in Lamberton, which is one of the areas that one of the clinics that Mayo closed and closed their ER, is that he says half the time their town can't even process a credit card in the gas station because there's no broadband that's functional. And then these facilities oftentimes lack, the PPE, which has been a struggle that I know that Rose Roach really knows about, and MNA has really led in fighting for our facilities. They lack ICUs, and even if they have an ICU or a ventilator, they may not have the staff to actually provide the care in that facility. And then, of course, we have higher levels of undocumented in some of our rural areas. And then we have patients who are older, and we know those patients actually have more chronic lung disease. So there's really, when we're trying to fix this problem, there's intertwining factors. One big factor I know, speaking for Land Stewardship Project, is that we are losing our family farms to corporate ag. And with consolidation of farms and the loss of each family farm, we lose 7 Main Street businesses. And then we can talk that there's really an extraction of wealth from rural areas that really feeds some of the resentment that we see in rural areas. This feeling of abandonment. I know that there are dairy farmers who are working 100 hours a week and yet making only $15,000 a year from their actual farm income. And of course, there's a shortage of elder care and childcare workers, and these home care workers and childcare workers are suffering really extremely low pay. So, and then broadband, as we've talked about. So all of these factors mean that we can't attract people who want to live in rural areas. We can't keep young families there. So just, I think what it's gonna take is a real shift in priorities. You know, there's this question of saving facilities, but we have to save people. You know, this farmer from Lamberton that I talked to the other day was saying, you know, don't I count? I'm a human being. You know, so it's a question of, are we going to make sure that all our people are cared for? You know, so there's a lot of talk about trying to increase reimbursement in our public insurance programs. You know, that's not the sole solution, because these rural hospitals, because of their low patient volumes, need a guaranteed source of revenue to support essential services. And so one of the things that has been talked about is global budgeting, you know, paying per capita to cover the cost of maintaining critical care facilities in rural areas. And there's trials. Maryland has been doing this for 10 years with 10 hospitals. And Pennsylvania is just starting this with 18 hospitals. And what they find is that if you focus on wellness, care coordination, primary care, follow-up, you know, your community health improves and your finances will improve. So I think this is something that I'd like to see talked about, and I've heard people bring this issue up because I think this is one of the ways that we might be able to save rural healthcare. So these are some resources that will be sent out after the program that were like critical to me in researching this talk. So thank you so much. Let me see if I can stop my share. Thank you so much.
Thank you, Dr. Borrud. We had not initially scheduled time for questions, but you have ended a bit early. Would you be open to a couple of questions, Dr. Borrud?
Certainly, yes, thank you. I wasn't sure, I didn't want to run over, so absolutely.
So we do have a question about the cost of medical school. Do you know of strategies that have been suggested to mitigate the high cost of medical school?
Oh, and I know that there's somebody watching this, Dr. Crossan, who is with our University of Minnesota Medical School, who can probably speak to this more than I can. You know, I'm not sure that I can. I was fortunate in that I was able to do in-state tuition at the University of North Carolina, and ended up with $50,000 debt versus my thought of going to Albert Einstein Medical Center in New York City, which would have been more like $300,000 debt. And therefore, there was no way that I could have even considered doing a primary care specialty. So I'm sorry, I'm not sure that I can speak to that. Is there
Did
another?
they not used to have some kind of incentive program for doctors to practice in rural areas?
Yes, and yes, that's absolutely true. You know, and I don't know if that's still in existence. You know, perhaps if somebody knows, they can put that in the chat. But no, absolutely, there has been where you get your medical school debt paid off if you will work in a critical shortage area, and I think that might still be in existence.
All right. We have a question on the infant mortality rate in Minnesota. Do you know if it has changed over the last few years?
I don't, although I'll just reiterate that we are facing increased closures of obstetric services. And one of the places that is studying this is the University of Minnesota. And if you go to the resource that I had in the last slide, which, you know, let me say, it's the University of Minnesota Rural Health Center. That they have researchers there. I think Dr. Carol Henning, I think her name is, who has done quite a lot of research on this, and you will be able to find information about that and perhaps communicate with her about that.
Dr. Borrud, would it be, with your permission, I could help with a couple of questions?
Oh, absolutely.
It's Anne. So Senator Marty's proposal includes, for the cost of obstetrician, suggests that the state would cover, in his Minnesota health plan, the state would cover liability for physicians, which would remove that barrier. And he's also put a lot of effort into talking about workforce development and, providers distributed properly around the state, including subsidizing the cost of education for physicians and other providers. There's so many good things in that Minnesota health plan that would help so many of the problems you just discussed.
Yes, I completely agree. I completely agree. I mean, it's interesting. I was just talking with one of our rural Republican legislators who himself has a chronic health condition, paying $15,000 a month for medication support for his chronic condition, who acknowledges the system is completely broken. We need solutions. So I think healthcare is one of the areas where we can perhaps begin to bridge across our differences, our political differences, because this is something that certainly affects our rural communities significantly. So thank you so much.
We have one other question here that just popped up. Could you speak at all to the person's termed it corporate Medicaid programs, but I'm not sure it's corporate, but are there corporate Medicaid programs that are prevalent in rural areas?
This is a good question. I know that there is some effort at developing kind of cooperative systems based in counties that help to try to cover care. I'm not sure I can speak, and if somebody else can speak to that, I'd love to hear from you. But certainly one of the big problems with both our Minnesota care program and medical assistance is that they have been managed by corporate managed care operations that are essentially, I compare them, and I think Representative Tina Liebling can speak to this too, that they are akin to the Pentagon in that the costs to provide care in those public programs are like a black box. We have no idea exactly how they're paying for the care in rural areas. This is proprietary information. We really can't access it. There needs to be transparency about the costs that we are paying as a public resource to provide care in those public programs. So I think one of the big solutions to being able to expand to universal healthcare in Minnesota is to extricate our public systems from this managed care, from these managed care corporate entities, and do direct contracting with providers.
I don't know if what your opinion is on this. Someone asked, how do you attract doctors to rural areas given the amenities deterrent?
We really need to reinvest in rural areas. Clearly broadband is one of the things that keeps people from being able to actually run businesses. There's a lot of people right now who want to escape to rural areas where there's maybe perhaps cleaner air and more room for their children, but we need to invest in our schools. We need to invest in infrastructure. And then as well, if we had universal healthcare where people's employment is not based to, tied to, if their care is not tied to employment, then people could start up businesses and live in rural areas. Since a lot of small businesses has been brought up by Dr. Brockie initially, there's a lot of small businesses that literally cannot afford to pay for insurance for their employees, or if they do, they can subsidize for an individual employee, but they can't subsidize for a family plan. And those family plans are extraordinarily expensive, for these small providers in small markets. And so if people were able to buy competitive, affordable plans through a universal health plan or an expanded Minnesota Care that was not tied to corporate entities, people could afford to start businesses and live out in rural areas. And people would if they could and afford to.
Okay, thank you so much. I'm going to end with one last question. Could you speak a bit about how global budgets for hospitals would help solve this problem? And also if you could talk about what Pennsylvania and Maryland are experiencing with their experimenting with global budgets, if you know.
Well, it's an area I wish I had more time to really research. It's something that just came to my attention in the last couple months. But what I know is that, you actually, pay on a capitated basis for like a population of people so that you have a guaranteed income. It's not based on fee for service. It's not based on payment for procedures. And so when you have a capitated kind of payment for caring for a population, you can focus on wellness, you can focus on prevention. And this is something that Maryland has found, is that that they actually can have increased financial viability by focusing on primary care, chronic care management, follow-up, coordinating with community services, wellness services, so they can actually lower cost by doing this. And again, we all know that if we can actually provide preventive care for people, it would be less expensive. I heard from an obstetrician the other day regarding paying for our undocumented. They need to come into a healthcare system. Right now, they can't buy insurance. Now you have a woman who's pregnant in a rural area who never gets obstetric care. She might have preeclampsia come in at the end of her, term and cost the hospital $200,000. We could save a lot of money if we actually took care of everybody and did preventive care.
Absolutely. Thank you so much. We are going to move on. I do believe your slides, we can send your slides out to the participants. Okay. Yep. Thank you so much. Next up, we have our the man who wears many hats, Don Pylkkanen, to talk about the legislative priorities for 2021. Turn it over to Don.
Good morning again. The man with, I guess, two heads, the treasurer's head and the legislative committee liaison head. Thank you very much, Dr. Borrud, for your great job in laying out very tough information describing the rural healthcare crisis in Minnesota. And there was one slide that is very dire that you presented, showing the graph of the escalating healthcare costs for Minnesota and us Minnesotans. And I think the graph went up to like 2018, something like that. And this is from the Minnesota Department of Health. I think what you showed was part of what the Minnesota Department of Health reported to the legislature in 2019, that by extending that upward graph of spending by 2026, Minnesota will be spending 19% on healthcare. And that is just a very unhealthy economic picture that we're looking at, and what health HCAM is addressing. The bottom line to that picture is cost containment. And you said so many compelling things about the plight of individuals and the rural hospitals, and one of that being the rising costs, the rising costs of deductibles for folks to be able to afford the front end, the premiums, and how the hospitals, the rural hospitals, have to eat that deductible for caring for the rural patients that are suffering with those high deductibles. So you presented information that gets at my legislative committee report this morning. As HCAM begins work for the 2021 legislative session, an important bill needing our attention has been introduced. It is HF 11 that calls for expanding eligibility for Minnesota Care, establishing a public option, and recommendations for an alternative delivery and payment system. And our alternative payment system is key here. HF 11 is authored by Representative Jennifer Schultz, Duluth, who was a panelist on healthcare payment reform with Senator John Marty and then Senator-elect Ann Johnson Stewart at the November quarterly meeting. Although HCAM sees some significant problems with HF 11, this bill has gotten significant support from progressive organizations in the state. At the time of its first committee hearing on January 26th, there were 24 signers on a letter to the governor and legislative leaders of both parties supporting HF 11. Among the 24 signatories are Land Stewardship Project, Minnesota Farmers Union, Main Street Alliance, Minnesota Doctors for Health Equity, Take Action, Isaiah, and multiple labor unions. HCAM recognizes the value to many Minnesotans of expanding Minnesota Care to more individuals, families, small businesses, and farms. This gives us the opportunity to discuss with organizations, constituents, legislators, and the public what we believe to be an alternative payment system. This is key. And Dr. Borrud, I think you did touch on that in your presentation. It's key because what we're looking at actually saves money, which is the fiscal basis of the single payer system. It's essential to support and improve the portions of HF 11, which are intended to manage the program in the most cost-effective method. In essence, to remove the insurance companies from the role of marketing and administering the plan, which is our recommended alternative payment system for Minnesota Care. It's the intention of HCAM to work with the other progressive organizations in Minnesota to accomplish these goals in the interests of improving healthcare for everyone, while heeding the economic reality that this can't be achieved without what I was mentioning earlier, without containing the state's escalating healthcare costs, which will consume 19% of the state's economy by 2026. And that's more than housing and transportation. And that's according to the Minnesota Department of Health's report to the legislature a couple of years ago. You can learn more about HF 11 at a Zoom meeting on healthcare legislative overview for 2021. And that's going to be presented by HCAM's legislative committee. And that's this Thursday, this coming Thursday, February 11th, 6:30. So keep your eyes out for the notice coming up. HCAM remains committed to achieving single-payer health care for Minnesotans. We will continue our strenuous efforts working towards that goal while simultaneously working with our allies. Last Monday, several board and legislative committee members met with Senator John Marty to discuss single-payer strategies for the 2021 session. The Minnesota Health Plan, the cost study bill, primary care case management, PCCM bill will be introduced. And as what was indicated earlier, although these bills won't have committee hearings in the Senate, we will work with Senator Marty on educating constituents and legislators on the single payer principles of the Minnesota Health Plan and how the cost study and PCCM bills based on these principles are advancements to the Minnesota Health Plan. Thank you. And we're looking forward to having you with us on the 11th.
Thank you, Don. I did just put in the chat that the registration email for that February 11th event will be sent tomorrow. So look for that if you're on our HCAM email list. If you're not on our HCAM email list, good reason to sign up. You can sign up on our website. All right, next up, we have Rose Roach, the Executive Director of Minnesota Nurses.
Well, good morning, everyone. And as always, greetings from your nurses. Dr. Borrud, I just want to say thank you for making it clear that the only way that we're going to save our rural hospitals and healthcare access in the rural areas is through a single payer healthcare system. Regional health planning has to be focused on community health needs and not on corporate healthcare greed. It is such an inhumane system that continues to harm people based on their geography, their race, and their socioeconomic status. So all in on the Minnesota Health Plan and or even better Medicare for all. So I just want to start by giving you a little bit of an update in regards to what's going on in the world of labor. On February 18th, Carol Engelhardt and I are going to do a presentation to the SEIU Healthcare Minnesota Executive Board, hopefully getting their members more engaged in our movement through education and opportunities to actually come together with us and continue to build our movement. I am also engaging in a conversation with the Minnesota AFL-CIO and the national coordinator from the Labor Campaign for Single Payer. We are going to be trying to put together a conversation inside of the House of Labor to talk a little bit with the unions that are sort of what we call yes, but unions. So those are the unions that say, yes, everybody should have healthcare, but how is it going to impact us? That is mostly a focus on the unions that have Taft-Hartley trusts. And so they therefore offer to their, their members get their health care through the Taft-Hartley Trust. And we need to have those voices at the table. It's critically important that everybody feels they have an opportunity to speak to this, to be heard, so that we can figure out how we can all work together to actually make guaranteed health care for all a reality for us. So I'm excited about entering into those conversations. Just a word about the fact that, as everybody knows, since we last met, there has been, basically the shutdown of St. Joe's for the most part in relation to at least all but COVID and some mental health beds that are remaining at least through the end of this year. Dr. Borrud touched on this issue of hospital closures and closure of healthcare facilities overall. So I just wanted to say that there is some discussion going on at the legislature around different ideas of bills that would actually take a look at this insanity that we're dealing with, and hopefully will look at different avenues for whether we create a commission, some sort of a health authority board that would have to approve closures. There's lots of different ways that we could potentially do this based on what other states are doing. And right now, we don't have anything on the books in this state that say anything about closing healthcare facilities, just about how you can build them on the front end. You have to go through a lot of hoops to build a hospital. You don't have to do anything to close one. That seems out of balance. So we are going to look at trying to take that issue on in this next legislative session. So stay tuned for more on that. A word about the national bill, HR 1384. I believe that Representative Jayapal is going to be reintroducing the bill towards the end of February here. Important for us just to keep working on Representatives McCollum, Craig, and Phillips to co-author the bill. I'm going to put Linda Gridley on the spot and just thank her for her willingness, just as of yesterday, to volunteer to be the Congressional District 4 National District Leader for us on the national campaign to win Medicare for All. Linda's going to be in the process of getting set up as that district leader. So we will make sure that we get that information out to any of you who are in CD4 and can, as I am, and help us see what we can do to really pressure Representative McCollum to get on that bill. So thank you, Linda, for doing that. I want to say a word about the national public option conversations that are going on. One in particular has to do with the idea that we should just lower the age of Medicare. So something to keep in mind, because even I believe the Jayapal and the Sanders bills both have that as part of the transition from our current system into our full Medicare for All system. That makes sense in that context, but just breaking that out all by itself and saying, well, here's the way that we fix our healthcare problems in this country is to just lower the age of Medicare. Just some things to be thinking about in relation to that. The current law actually says that if you're still employed, so if we lower it to 55, right, from 65. Lots of people are still working at 55. If in fact your employer provides you health care, health insurance through your employment, you can access the Medicare. So we want to be careful about just saying, oh, gee, this is the panacea, this is the thing to do. There's lots of things that have to change in order to really make that something that is worthwhile. The other question is whether or not this kind of a Medicare expansion, is it just another Medicare Advantage plan? Because we know Medicare Advantage is the privatization of our sacred Medicare system. We don't want to go further down that path. So something to keep in mind. And if we're going to push for a lowering of the Medicare age, it is important to remember, as many of you know and have pointed out, if you are on Medicare or have, family that's on Medicare, that system isn't what we want it to be under Medicare for All either, right? People have to buy the supplemental plans and, and there's all kinds of stuff that is right now not where it needs to be because it's an 80-20 plan. So if we're going to say, let's lower it, then let's fix some of it in the process of doing that as well to make it really worthwhile. No more Medicare Advantage plans. We should just get them out. And we should combine Medicaid and Medicare into a single plan because Medicaid is an inherently racist, product as it's set up now. Remember, it was done as a compromise to the southern states, allowing them to control by the state who gets Medicaid and who doesn't. And Medicare is obviously a federal plan and it's administered federally. And so it would be much, much better if we could bring those plans together, expand Medicare and everything it has to offer to everyone, not Medicaid, which has the lower reimbursement rates, et cetera. And we should, of course, include in their negotiation of drug prices. So, in reality, this idea of the public option, it's never really made much sense. If it competes on a level playing field, then the public loses because the private plans define the playing field. And the private plans oppose it because they won't let it compete on any other playing field but their own. So it seems somewhat inconsistent. You know, Michael Leidy, I think most of you know, is a former National Public Policy Director for NNU. Currently he's serving as an organizer with the National Union of Healthcare Workers, and he's a Healthy California Now leader. He recently wrote in an article that was entitled, "How to Win Medicare for All Under President Biden." And he laid out a couple of important facts that I just want to quote. He said, when a federal ACA fix bill moves through committee, there will be a strategic opportunity to demand a markup of the single payer bill and the inclusions of key policy priorities, such as lowering prescription drug prices and eliminating out-of-pocket expenses in whatever bill ends up emerging. This process could bring media and political attention to the policy advantages of Medicare for all. There's a set of administrative actions the Biden administration could take to immediately expand healthcare coverage, including enrolling everybody in Medicare for the duration of the pandemic, as incoming Senate Budget Committee, well, now he finally is the Budget Committee Chairman, Bernie Sanders has proposed. Passing additional pandemic-related healthcare legislation will be essential, so pressing for that package to include coverage for all out-of-pocket costs for everybody while covering the uninsured is both good politics and good policy. Biden's Health and Human Services Department, under the leadership of Medicare for All supporter and former California Attorney General Xavier Becerra, can administratively grant state innovation waivers to establish single payer in the states. Initiating a waiver would change the argument from whether to implement single payer to how do we implement it. And it's arguably the fastest way to move the issue politically while demonstrating the policy advantages of such a model. Other states could also then follow course. So again, highlighting the Healthcare Emergency Guarantee Act, putting all the uninsured into Medicare during the pandemic, while covering all of the out-of-pocket costs for the insured during the pandemic to be paid out of Medicare would also provide a great bridge to moving Medicare for all. I'm going to just say one word about, for any of you who are kind of wonky and looking for some new angles to figure out ways to bring more people into the movement and more ways in which to talk about why single payer is so advantageous. Some of you may have heard of something called OPEB. That's the Other Post-Employment Benefits. So this is for mostly early retirees, in some cases, retirees even past Medicare age, who have through their employment some sort of a retiree health benefit. And sometimes it's paying for a Medicare supplement plan. Sometimes it's covering the gap between when you early retire to Medicare age. But either way, it's costly on the books of employers, whether they are in the private sector or the public sector. And so the reason I'm bringing this up is here's a big ticket item that is on the balance sheet for employers that, guess what, under single payer, come off the balance sheet. So I'm thinking through some really creative ways in which working with folks to maybe start with our public sector. You know, Julie Blaha is our state auditor. Julie is a former, she is a teacher. She's a former secretary treasurer of the Minnesota AFL-CIO. And I think a conversation with Julie in regards to what is that cost on the state books for paying for retiree health benefits, because we can make the case then to show how beneficial that would be if we could potentially get that off the books by just guaranteeing healthcare for all of us, regardless of what our age is, what our employment status is, et cetera. So just something to be thinking about as we you know, gear up for all the various arguments that we can make about how positive it would be for all of us to be under a Medicare for all type system. Thanks, everybody.
Thank you, Rose. I think there were a few questions in the chat and Q&A if you're up for answering those in there. But we will be moving on with it's Ann Jones to finish up our meeting content.
Whew, thank you. This was so awesome this morning. I can't say enough great stuff about all the content so far. I'm going to talk about education and outreach, building our base, and some announcements. But just in case you need any more reason to get fired up this morning about this issue, about fixing how we pay for healthcare, this is a little piece of information. The nonprofit CEO compensation just came out recently, but this United Health Group is a for-profit commercial health insurance company based right here in Plymouth, Minnesota. And one of those Star Tribune newspaper articles about CEO pay printed the pay for the CEO of United Health Group in 2018, 52 million and something. And then someone else wrote in a little letter to the editor and said, oh, but wait, the cost of the top 6 executives at United Health Group, 162.4 million in pay in 2019. Now, Wendell Potter, who's a commercial insurance company whistleblower, has been screaming about the fact that the commercial insurance industry had a banner year last year in a terrible economic downturn related to the COVID-19 pandemic and associated economic troubles we're in, and yet the commercial insurance companies made record profits. There is really something wrong with not only how we're paying for healthcare, but how we allocate resources in this country. So we'll throw that out there for you to think about this morning. And as we listen to the work we have to do ahead of us, Healthcare for All Minnesota is primarily working really hard on bringing more people into the fight and creating more of us. So just to kind of say again for the many umpteenth time that we need more of us. We need people who are educated on these issues. Thank you for coming this morning, because every time you listen, I think we learn more about making our case for healthcare payment reform. So having the confidence that we know why we're doing this, we have both the facts and the values on our side, I believe. When we can do in-person events, we will, of course, be asking people to do some of the things they've been doing as leaders and as volunteers, which are more community outreach and organizing events. Carol's suggestions about doing some outreach along with some fundraising is going to be a great opportunity later on this spring. We could always use more people who are willing to give talks, but I just want to say it's actually a lot easier to provide speakers for groups you are part of. The online option is quite easy to accomplish, unless there's an area that doesn't have broadband support, of course, but any areas where we can provide someone to speak to groups of any kind, civic organizations, issues-based organizations, church groups, et cetera, we can easily do that. And again, we'll have some opportunity to continue to hold our elected officials accountable for their commitment to fixing this problem. We're all about the business of creating the political will to make change happen. This is just a worksheet that I propose that people can use. If you're talking about coming up with who you might be talking to in your own personal network, this is a good way to keep track of that. We'll get this up in our toolkit on our website under resources. And while we someday hope to be able to go back to the Capitol and be a presence there when we are in the position to push for legislation that we really want, I'm hoping for a day when we can make the Capitol look like this. I don't know which group this is, but the biggest group I ever saw at the Capitol was teachers. They're really good at getting people out. But I want to back up a minute and say that I just read a paper by the president of the One Payer States, which is another website you can go to. It's a consortium of the states around the country who are working on a single payer system, state-based single payer health plan for their states. This Chuck Pinocchio is a professor at a university in Pennsylvania. And he wrote a paper where he talked about the 5% solution. Out of crisis comes opportunity. So even though we need to mobilize large numbers of people at critical moments in this fight for single payer, the history of social movements suggests that it takes a relatively small but persistent, tenacious, visionary activist with something like another 10% providing financial, intellectual, and structural assistance to affect radical or revolutionary change. And I would note for good or ill, because we've certainly seen some downsides of activist groups in the last few years, especially recently. But I wanted to say that never doubt that what you are doing is important and will make a difference in as we develop strategy and tactics going forward. Create or increase that sense of urgency, take advantage of tipping points, form the alliances we need to make this happen, and continue to build a movement to win this fight. So our Education and Outreach Committee, I think I've commented on this before, replaces our in-person events for right now. Education continues to be a primary strategy for outreach. Healthcare for All Minnesota is the lead organization. Physicians for a National Health Program Minnesota is participating. And we meet online frequently to plan events. We are marketing to email lists and our allied organizations. Combination is a content of speakers, panels, and videos. We are very open to content ideas and speaker suggestions. I think maybe Dr. Borrud might be added to our list of great speakers after today. I hope you're willing. And we do have a lot of the events we've done are on our Healthcare for All Minnesota YouTube channel. And you can also look for information on the website. And then also, I really suggest viewing those Fix-It videos if you haven't, and sharing the short ones, because they really do a good job of explaining basic concepts and principles and are great to share with other people you know. Even you can pull them up on the website and share them online. So announcements for today. Don talk to you about the event we have coming up on February 11th. We're going to do a deeper dive into the legislation that we think might be relevant to this work this cycle. And that will be presented by our Healthcare for All Minnesota Legislative Committee. Don is the board liaison. On Thursday, February 25th, in recognition of Black History Month, we are going to show the documentary film called Power to Heal. And it's about the Medicare and the Civil Rights Movement of 1965. It's a very powerful film. That will be 6:30 in the evening. You will get invitations for it. I really encourage you to share this with people who you know who are you might invite, who might be interested in not only our issue, but just in knowing a little bit more about how Medicare came about. I, living in Minnesota, growing up and living my whole life in Minnesota, had no idea that we had such a terribly segregated healthcare system in this country before the Medicare law was passed. So I will encourage you to consider this is the flyer for this documentary. Again, it's a very powerful film, and please encourage people who you know to join you in viewing this documentary. It's also, it's a turnout event as well. Continue to call, write, or respond to action alerts. As we found, we don't send out very many, but when we do, it's something important. See the calendar for other meetings and events. Please send any events to us that are scheduled for your local groups or events of interest you think we should publicize. And then again, we can provide speakers for local events. And Rose mentioned the emergency expansion of Medicare and the Medicare crisis program. There are two pieces of legislation that were introduced or that were proposed in 2019. I don't know how far they got as far as the process goes in Congress for introducing these bills, but these could use support. We need to be telling our own members of Congress that these bills are being proposed and need their support. So if you want to take your phone camera and just take a snapshot of that screen and then call the Capitol switchboard, you can give your feedback to your members of Congress and our 2 state senators. And then I guess I'll say stay safe, Minnesota. And we can wrap up.
Thank you, Anne. Thanks to all our speakers today. Thank you to our attendees. This meeting has been recorded and it will be posted on our YouTube channel. We will be sending out the PowerPoint slides, particularly from our featured speaker, Dr. Aleta Borrud. If you have questions, you can certainly contact the people that have provided their emails. And we hope to see you at future events. You can definitely check our calendar for signups. So if you're not on our email list, but we hope you will sign up for our email list, you can go to our calendar of events, which is on our website. And you can also look on our Facebook page. We generally have Facebook events for all of these webinars and educational offerings. Thank you again. Have a good day, everyone.